Feroz Dinah here again. I'm talking about surgical planning for mainly primary total hip replacement. We'll talk a bit about some clinical features that would affect what you do for the patient in terms of the implants. We'll talk a bit about X-ray features that would affect, again, what equipment or kit you would need in theatre to preempt any problems you might have. We'll talk a bit about trauma CAD planning, and I won't talk too much about 3D or patient-specific planning, as this is not common in primary hip replacement. It's reserved mainly for revision surgery or if you have a robot in the hospital. We'll then wrap up after that. So in terms of clinical features, the age of the patient does unfortunately or fortunately affect what implants you should be using. And certainly there's a drive now to consider cemented implants for older patients and reserve the uncemented ones for younger patients. Certainly in the NGR, the best performing implants are cemented hip replacements. And there's some suggestion that there's no need to use the more expensive uncemented implants even in younger patients. As you've heard with the Getting It Right First Time movement or policy and guidelines, we are supposed to reserve ceramic and ceramic for younger patients and use metal on poly for most of our patients over the age of 70 or 75. In the history, there are a few features that would suggest that there's an increased risk of dislocation, things like dementia, previous stroke, or ongoing Parkinson's. And in those patients, as part of your surgical planning, you may want to consider the use of a dual mobility cup to reduce the risk of dislocation. Other features are things like leg length difference. You need to warn the patient or explain to the patient if you are going to correct that, particularly if you are lengthening the leg, then you may have to warn them about sciatic nerve palsy. In DDH, the more severe DDH patients need to be counseled about the possibility of needing a femoral osteotomy, but also you need to be aware of the different anatomical variation or abnormal anatomy because of the hip dysplasia that would affect what implants you use or need to have on the shelf as backup. And lastly here, having a stiff or fused spine may increase your risk of dislocation. In some patients, that may be an issue as well. So as I said, plain X-rays are very useful and are often all we need for primary hip replacements. Sometimes we might use a CT scan if there are issues around pelvic discontinuity or fracture healing. And more recently, there's some push to use sitting and standing X-rays to assess for spinal pelvic mobility or actually looking for spinal pelvic immobility. So this is a protrusory hip as evidenced by the femoral head being medial to the ilioischial line here or the teardrop area. The main issue with protrusory and arthritis is that the hip becomes very, very stiff and often is difficult to dislocate, often even impossible to dislocate. Rather than break the femur, we advise that you cut the neck in situ and deliver the head with a corkscrew as you would for hip hemiarthroplasty for hip fractures. I hope you can tell this is not just hip arthritis. This is obviously hip dysplasia. You've got undercovering of the femoral head. You've got a very shallow socket, and you may have retroversion. You need to be aware of this before you start the operation in terms of having the right kit available to make sure the operation goes smoothly. X-rays again of failed hip fracture fixation for different reasons I may add. So here the main issue is about having the right kit in theatre to remove the implants, but I'll also mention the fact that you need to make sure that your stem bypasses the last screw hole. And for example, the debris C stem does not, and therefore you need to order in the long debris C stem, whereas the Exeter, the standard Exeter stem, does actually bypass the fourth hole without too much trouble. There may be some cement extravasation or extrusion through the screw holes, but it's not usually a big problem. So this looks like a fairly standard hip arthritis problem, and it is, except for the rather serious lumbosacral arthritis going on here, and that may cause problems later on. So we'll talk very quickly about trauma CAD planning. This is the computer pre-op plan that gives you hopefully an idea of the size and position of your implants. And I think failing to plan is probably planning to fail. And certainly in the early stages of your career as hip surgeons, you should do some planning until you may get more used to it. So this is what trauma CAD looks like after going through the various introductory screens. The most important thing is finding the calibration ball, and if there is one, the computer will pick it up automatically. If there is not, you can use the oversize function here and put it at 120% of magnification to get a reasonable approximation of the implant sizes and shapes and positions. Sorry. So I tend to also use this function to look at the leg length, particularly when there is a big difference. And the next thing then is I tend to use the cup first, and so I've chosen here Dupuy cup. I've gone down here to Pinnacle cup, and the computer suggests the best fit, which is not always accurate. We'll come in just a minute. So you can see here the computer suggests a 48 size cup, and this actually is just the right size for the femoral head, and therefore the cup should be bigger. In fact, normally if you use this to size the femoral head, the acetabular cup is 2 to 4 millimeters bigger than that. And that's a fairly good rule of thumb. So this is what the computer suggested. And the other problem here is that it's far too lateral. I want to go more medial, closer to the teardrop here. So this is my position. I've gone to for a 50. I've moved immediately just close to, not exactly on the teardrop. And that's where I'm going to put my cup. Next, I'm going for the stem. So same again, Dupuy, I've gone for stems. I'm choosing a Karai stem down here. And again, the computer suggests the size and position for this patient. And it's suggesting a size 8 with a 28 head and a standard offset. And you can see this is a bit small, there's a bit of gap here. And also it's a bit low and sort of skirting the femoral neck and calcar area. So I want to change that. I moved it up to clear the neck, and it still looks small. So I'm going to change that again. And I'm going to a size 10 with a 32 head. And again, it was a standard offset because it seems to fit the patient quite nicely. So I don't aim to get the points to overlap. And my more important concern really is this here. And if you didn't notice before, we'll go back a couple of slides. Previously, by the computer's suggested position, I had quite a lot of change, and that's not good. You want to get maybe a mil or two of change, but not too much more than that. Obviously, if the leg is longer or shorter, then you can adjust accordingly. But usually, if you put the cup in the right place and the stem in the right place, usually matches up quite nicely. And you can obviously put the stem prouder or deeper if you want to correct a leg discrepancy. So the last thing we'll do there, and after that, is I tend to measure how far down from the tip of the trochanter I am in terms of knowing how deep to put my stem in. And here I've got about 1 centimeter. And then last but not least, you should save this to your PAC system to make sure there's a record of it on your system. So in summary, therefore, sometimes clinical features from the history examination will determine what implant you use for the patient. X-ray features give you an idea of what could go wrong in theatre during the procedure. You have to look out for that. Trauma CAD planning gives you a handle and a feel of what size and position you're going to go for the implants. Thank you very much.